I'm just going to call out over that we're abstract. So, what is an abstract at ADA? It is a small study of sorts where small numbers of things are done, right? We did one on our pharmacy discharge program that looked at A1, like the number of scripts that our pharmacists through our 403B program, by the way, um, are filling for us so that we don't even have to touch them, and the number of scripts that didn't have to come to the providers to reduce the burden of the providers. At ACE, we did one on using the islet, actually insulin pump specifically, and post pancreatectomy diabetes. And I think our number was 7 or 8 patients, right? So there's small things that you look at and go, huh, should we do more of this? And people walk around and learn about you. There's poster time and they walk around and learn about it. So a couple of the things that I saw that I loved was one out of Saudi Arabia that looked at people with type 1 and A1C versus CGM metrics. And the CGM metrics outperform the A1C in predicting microvascular complications. So I'm a huge technology person. Everyone with type 1 should be on technology. Those are the ADA guidelines. If they don't want to pump, great, but at least get them on a sensor, right? That's an AID is recommended, although people don't always choose it, right? So they looked at this. They looked at retinal exams and whether CGM was active at least 70% of the time in the last 30 days. And they looked at diabetic retinopathy and urine protein time in range of greater than 50%. Remember, we're aiming for 70, but even time in range greater than 50%, there was lower diabetic retinopathy, 20% versus 29%. Look, 50% is never what I want. And it's like, okay, wait a minute. Maybe when we think about even 30 to 40 or 40 to 50 or 50 to 60, increasing that time in range even just a little bit, we're making a difference. Protein in the urine, 10% versus 23.4%. Again, like just at 50% of time in range. And then the composite microvascular complication, which they created a tool to look at the composite, was 29 versus 42%. So CGM metrics actually, this was a study of 370 persons with type 1 in Saudi Arabia. This was impressive to me. This makes me realize why we're using CGM, and as a clinician, makes me remember that just because you're not at 70% or 80% or 68.5%, we're still reducing complications, even at those lower percentages when people are just struggling with their daily lives, like we were just talking about, right? So it's not all lost if you're not getting to 70, but this was fundamentally different than what we've seen in the past. What other things stood out? The use of C-peptide as a marker in preservation of beta cell function. So, so what is C-peptide? C-peptide is the residual of beta cell production. So when you run your car in your garage, you're not supposed to keep the garage door closed because it produces carbon monoxide. When you make your own insulin, your body produces something that we can measure called C-peptide. For those of you that don't do this as a day-to-day, right? So I can measure C-peptide, which means you're making your own insulin. The insulin that you give in your arm or your pump or your whatever, we can't, we can measure that in a clamp study, but we don't, right? This is different. This is endogenous insulin production. So we have not had a way to look at preserving beta cell function because the C-peptide wasn't recognized as a measure of preserving beta cell function. So there was a lot of talk on this about preserving beta cell function. Because in long-term studies, people who have beta cell function have less complications. They have less retinopathy, they have less kidney disease, they have less heart disease, they have less everything. And it's interesting because you think, well, if you've had diabetes for 25 years, you have no more beta cell function. And for people like me, I'm at 55 years, 55. We've stopped counting, by the way. I'm always going to have 55. So don't ever think you're going to hear another number because we're really not at 55 anymore, but we say 55 because it sounds better, right? Palindrome, kind of like it. I'm a math person. There are people you would never have C-peptide. And interestingly, in the Joslin 50-year study, and in the EDIC study, which is the post-DCCT follow-up, people had still had some beta cell function. And the challenge is we don't know why some people still have some, and some people like me, then I'm like a vortex. I could take all your beta cell function away if you stand too close to me, right? So we just have to know that this is just what happens to some people. And so we can look at this residual beta cell function and measure it And then we can also then see if we can use medications or to preserve it post-diagnosis of type 1 or pre-diagnosis of type 1. We do them in the hospital sometimes, don't we? When you see someone come in with an A1C of 15 or some high number, but they don't typically, they're not presenting as type 1. So we do sometimes use them even in the hospital. We use them for Medicare labs if someone wants a durable medical equipment pump. But now we're looking at it differently and saying, what else could we use this for? So there were several different papers on that or abstracts and those kinds of things. So that was
Natalie,
pretty interesting.
can
Yep.
I ask you then, how will it change what you do based on, like, do you think you'll be ordering them more to help guide patients on their preservation and on their management?
So we use a lot of GLP-1s in type 1 in our practice. As a matter of fact, I'm probably the number one communicated person at from Blue Circle Health. They're like, "Well, your note says type 2." And I'm like, "That's not, well, they have type 1-ish and type 2-ish, and we dance them together, but they need proof that they have type 1 because this is part of their grant, their company status, or their nonprofit is they're seeing people with type 1. But like we use it all the time. And so knowing someone has a little bit of beta cell production, can I maximize that by using things like GLP-1? Is it a little bit safer to decide to use an SGLT2 inhibitor or not? So it will guide our clinical practice. And that really leads into the other thing that happened, and this is completely out of order, but teplizumab there was the data, the PEDS data. So now it's approved for 1 and up, and the PEDS data was read out there. So that's number one. But number two, the week after ADA, just last week, teplizumab was FDA approved for children ages 8 to 17 for stage 3 type 1. And that's based on this C-peptide measures, right? So the indication is from 7 to 18. Where it's coming by 25 is coming, like age 25 is coming. It's just be patient. We just had to get something out there, right? They had to go to the FDA to prove that C-peptide was the residual of because nobody knew, like people just don't all know, right? Um, but the guidelines or the labeling says within 8 weeks of diagnosis. So these are children that have just been diagnosed with type 1. And they also have a C-peptide greater than or equal to zero point 0.2. Because if you don't have any beta cell production, teplizumab isn't going to work, is it? And we would never want to give a drug that is infused over 10 days, or 12 days rather. It's a 12-day infusion instead of the 14, which stage 2 is approved for. And then another 12 days, 6 months later. And what they did was they looked at the C-peptide of the people that got infusion versus placebo, and C-peptide was preserved. So why do we care? Remember, it reduces the risk of heart attacks and strokes. The beta cells matter. If I had 6 beta cells, I'd be happy, you guys. 6. I would take 6 right now. Um, so ultimately, what are we doing? We're buying some time for the next thing, right? We're buying time for really tight glucose control, although I hate that word, right? Really high time and range, really high, and reduction in the burden because it's easier when your body's making a little in the background. Your highs aren't so high, your lows aren't so low. And we really do, it's that honeymoon period, right? We're really trying to extend that honeymoon period. So there was a lot on C-peptide and the measurement of it and how important beta cells are to preserve them as long as possible. To be honest with you, I don't see this teplizumab as the do all end all be all, but it's buying us time to get to the next thing, right? That's really how I feel about it is like you got a child right now in the ICU diagnosed in DKA. If I can set their glucoses, get them on insulin and stabilized and get out of that toxicity, that's where can we extend the residual beta cell function as long as possible as we wait for other treatments to come. Does anyone have any? Yeah, Monica, go.
I
Right, here
jump
we
in?
go.
Yeah. So I'm really excited for the additional coverage of teplizumab, and I know it's not everything like you said, but what struck me was that 8 weeks when we know
Yep,
so many people are, misdiagnosed or diagnosed later or delayed. Like I just feel like we're not going to
I know.
capture everybody then. And I'm
I
curious your
know.
thoughts on that, or if you're also as frustrated as I am.
I know this is what the study was,
Yeah,
right?
I
So this
know.
is like, post so we have to do like what the study said, right? Which was 7 to 17 with, at diagnosis. And it was actually 6 weeks, but they have 8, right? we're going to miss people because the good news is it's kids, and kids tend to not, that tend to get less misdiagnosed. In adults, we see a misdiagnosis every week in my practice. It's like every week I'm like, oh no, let's draw it, right? Um, so, um, Megan says, still having to beg constantly for C-peptides from PCPs. Yep, it is because if you're obese, you can't have type 1, except 65% of my patients with type 1 have overweight or obese as part of and I only see 16 and up, you guys. So, like, it is, or a person of color, exactly. I mean, God forbid you have and that's actually type 1 is growing faster in people of color, in Hispanics, right, faster than ever before. So, I mean, the good news is in peds, it tends to happen much more quickly. In adults, we're going to struggle forever for this because people don't see. So I think we'll have, but it's also how do I get an insurance company to say yes that fast? So there is going to be some like, yeah, we have 3 kids right now, that are newly diagnosed that would qualify right now. We'll see what happens, and we'll see what that discussion is with families. Um, I also see this as a side of like, okay, so if you think you want your child that's in a bed right now to get this drug, right, that is a bit of work, right? You need an infusion every day for 12 days. You need to get insurance to say yes. Someone's going to have to take off of work, right? We've made some progress. We have a Ronald McDonald House here that will put the family up. They can homeschool from there. We've made wonderful progress in our ped side for a lot of these things. Thank goodness for Jamie Wood, who is the peds endo with who we work with. So, and she's infused some of our young adults because peds is just a little more loving than adult care, right? Um, but the real challenge is going to be that 8 weeks. How do we get the insurance to approve it, get all of this done? And then can I, though, at the bedside say, so you're this interested in this drug for them? Can I screen your kids and you right now? And that's what I see this as is like an opening to get more people screened because the ADA guidelines now say screen everyone's first degree relatives. And we're not doing that because families are like, no, I don't want to know. I don't want to know if my child has type 1. I don't want them to have the misery that I had. And they don't realize that it's so important to do it that I'm hoping that it will increase screening even at the bedside or as quickly thereafter as we can for the families that even think about considering this new medicine or this new indication for the same drug. We'll see. Yet more to come, I'm sure, right? I mean, I think that's the best way to put it is more to come. Um, so did anyone have questions on that?
Megan has her hand raised.
Come on, talk to me.
So I just wanted to let you know that we used to work in collaboration with the University of Florida through their Echo Diabetes program where we had the no cost, I never say free, I say no cost because someone's paying the bill, right? So we had no cost type 1 diabetes autoantibody testing that I had boxes of them here. They would get shipped out every quarter. And then what was so beautiful is that Dr. Holler at the University of Florida would interpret the results, get back to our PCPs so that they would feel confident with the diagnosis and the interpretation from the endocrinologist. They lost their funding about a year and a half ago and had to discontinue the program for a little while, but we still had some kits that hadn't expired that we could still use and still some funding to test. But most recently, when they restarted the program about 6 months ago when they got their funding back, my organization could not support having a provider on the ECHOS team. So in order to be enrolled in the ECHO program through the University of Florida, you have to have at least 2 providers at your organization that will sponsor and be part of the meetings on their lunch break once a month and coordinate with the physicians and nurses through the University of Florida. And I could not get out of a 7-center FQHC, I could not get 2 providers that would sponsor the ECHO program. So that means that I no longer have access to no-cost type 1 diabetes autoantibody testing. So now we use their websites and we show patients where they can go in and test their family members and get the free kits and all of those things, but it's still a delay of care. Whereas before, I could just have them come in, poke their finger, take these blood samples, send them in. Dr. Holler would get the results within 2.5 weeks, and we could have definitive answers. But I just want to let you know, these are the kind of barriers that someone like me faces that's not at a provider level, that's at a nursing level, right? With my limited scope of practice, where I say, well, begging, begging. And it's because, the providers in this environment are double booked patients in 15-minute slots, 30 something patients, and they don't have the time on their lunch break to even finish a note, let alone take part in these meetings and take on one more extra responsibility. But it's just, to me, it's so frustrating because it just limits access. I would say that, most of my patients are uninsured or underinsured, and so the cost of these specialized autoantibody testing are up there. And so, even though our FQHC has contracts with Quest and LabCorp, it's still without these specialized testing. So just know, for people out there in environments, there is the Echo Diabetes program at the University of Florida where you could get no cost testing for these kind of things. You can enroll as long as you have two providers helping you out do this. But just know, like some of these things we're talking about, one of the things that really, really frustrates me is we have these things, but we have to route patients to breakthrough type 1, and we have to route patients to links to these free testing where they have to order the kit and it has to come in, and then they have to schedule an appointment to come in for us to teach them how to do it properly and safely to send it out. And it's just such delays of care when we could get this done so much faster. And then people change their mind. If we convince them today at the bedside in the hospital to go ahead and test their kids, but then 3 weeks later they don't get till they get the kit in, they may change their mind or say, they don't have that clinician or that caregiver in front of them that's saying, I'll help you do this. It's going to be okay. This is why we need to do it, because we're protecting, right? We're being proactive versus reactive. But I just wanted you guys to know these are the kind of limitations we have in primary care environments and federally qualified health centers, and it's enough to pull your hair out, right?
Yep.
So the reason why I've missed so many meetings, you guys, is I'm also taking part in an NIH funded research with the University of Connecticut and FAU. So that takes up a lot of my lunch break, a lot of with those meetings and things too. So I didn't want you guys to think I was abandoning you the last 6 months. That study that I've been participating in has been a lot for me. I'm learning all the barriers of trying to keep track of everything and my best friend red cap. So but that's kind of what's been going on. But I appreciate all your comments, but I just wanted you to know kind of what it's like in testing wise and an FQHC environment with little provider participation, what it's like to advocate for these things, especially for type.
Yeah, it is a barrier filled, right? There's lots of, I mean, we could have a whole call on this, and maybe that's what we should do, is actually think about doing some brainstorming on how do we address this, because we're doing the same thing. We're ordering kits for people who are uninsured or underinsured. We have to wait for them to come in. We have to mention it again. We have to, right? Like, yeah, this is a tough one, you guys. This is healthcare in the United States right now. So, okay, so let's go on to our next one. A couple others that I wanted to mention that I thought were pretty interesting. And again, these are abstract, so they're very small studies typically, right? Heart rate monitoring for early detection of physical activity-induced hypoglycemia. So they put people on heart monitors. They had them wear sensors, right? It compared it to activity-induced hypoglycemia is better than patient declaration. So the patient says, oh, wait, I'm low, or even step count alone. So the heart rate monitor alone caught 80.3% of the hypoglycemia. Person reported hypoglycemia was 50.3, and step count alone was 37%. So, are we a heart rate monitor person or not? Do you use your Apple Watch? Do you use your Ring? Do you whatever, like all these crazy, maybe it is worth what we're doing. And maybe when you see your heart rate go up by, and they didn't get into the deep details of, is it 10%? Is it 20%? But I think that we could, especially with people with hypoglycemic unawareness, we could help them say, okay, you're out for a walk and your heart rate starts to go up. You should pre-treat. I see that your sensor is still stable, but what if you just had a glucose gummy and then give it a little bit? Okay, now I have another one to try to address this and protect someone from additional hypoglycemia. So I thought that was pretty interesting because we haven't seen anything like that before. If you did attend ADA, it is in the abstracts. These are some of the abstracts that I went to that I actually took pictures of and loved. And so then the other thing that happened was there was a readout on the circuit trial with Control IQ in pregnancy. So recently, Control IQ was approved as an indication for pregnancy. It is the only pump in the United States that has FDA approval for pregnancy. Understand that the way they did it was they kept it in sleep mode all the time, and people really needed to interact with that pump regularly. We use it all the time in pregnancy, but it does speak to the power of that AID system. It speaks to the power of maximizing the settings in a system. So I thought that was interesting. And for people with type 1 diabetes, we ADA guidelines now say what? They say that we are supposed to be counseling anyone of childbearing years every single visit, that the fasting glucose is less than 95, 1 hour, 140, 2 hours, right? 120, and that where they are and what their journey to pregnancy is. Are you planning on getting pregnant anytime soon? Are you using birth control? If so, which kind? Do you want to see, do you want a fertility consult or not, I'm sorry, not fertility, but a high risk OB, maternal fetal, whoever you guys send to as a consult to talk about your risks, right? Because even if your A1C is 4.9 and you have type 1, you still have increased risks during pregnancy because glucose fluctuates and those glucose fluctuations can affect the pregnancy. So, this is the first. I think there will be others, but this was pretty exciting. It actually did happen before ADA, but there were presentations. The circuit trial readout was there at ADA. So the Blue Circle Health A1C reduction, I actually didn't know. So we don't plan these calls ahead. So I pulled the things that I thought were important. And one was that the Blue Circle Health, you guys, the A1C reduction, when they complete a circle, right? When they do the full Blue Circle Health circle, was 0.86%. That's incredible to me. So when I say I want you to go to Blue Circle, there's reasons behind it, right? An early exit was 0.36%. So still impressive. There are medications we prescribe that have less efficacy than Blue Circle Health, by the way. And that to me, I was like, right? So I thought that was really interesting, and it just talks to what we're doing and why we should, as clinicians, feel comfortable about doing it. So, I mean, I know I'm preaching to the choir now, but this is really important to me. So then let's see what else. Afrezza Inhale 1 in peds. So Afrezza, the Inhale 1 study in pediatrics was read out at ADA. And lo and behold, what was it, 2 weeks ago now, was it right after ADA or right before ADA? No, I'm losing my brain, you guys. I don't even know if I've unpacked from ADA yet. There was no pediatric indication, but it came right after. So it is now approved in children 7 and up. 7 and up? You guys. Oh, it's killing me. I don't have it at my fingertips. I will tell you
Well,
in a minute.
Natalie, will you look at that really quickly? I'll add in here
Yep.
too as just to like how does this relate to real world? So I started for those of you who are on when I said I was like, I'm trying to get into my endocrinologist's office. One of the things I left ADA wanting to do is try Afrezza. Like I've heard so many great examples of people using it to get rid of stubborn highs, to use it with exercise where you want to have a full meal, but you want it out of your system, the insulin out of your system before going on a long run, things like that. And so I'm like, I'm ready for this. I can supplement it with, use it supplemental to the pump I'm using because I can still log external insulin in my pump so I wouldn't be stacking insulin, etc. So I have all these plans, but I need to meet with my endo to be able to do it. And one thing that I need to do is get a functional lung study to be able to do it. So that's just a, kind of a reminder of like there are sometimes different barriers that you have to do to go get these, and it's a little bit more complicated than like, oh, Sarah wants to try Afrezza, and how do we make this happen? So just kind of sharing that real world experience about my journey to try Afrezza. It hasn't happened yet, and it may not happen till March 10th when I can get into my endo, but I'm really hoping we're going to be able to make it happen before then. And she's trying, she's great.
Yeah, I mean, this is the reality, right? I mean, if you call it's 6 and up, by the way, you guys. So peds 6 and up, which actually, so, I mean, Sarah, I think that's really interesting that you literally can't get in. We actually at our office just created something we call Diabetes on Demand. And 3 days a week, you can just log in and get an appointment. And you actually see our amazing PA named Claudia, who has type 1. This isn't her coming out party. She says it all the time. It's not like I'm saying things she doesn't need or doesn't want you to know. She has type 1. She's amazing. And she will just get someone back into our system to provide that in between where we could where we can get someone a note for their Medicare pump supplies for type 1, whatever, an adjustment because they got a shot of steroids in their shoulder and now their blood sugars are running high, and it's another call at in my life at 5:30 or 6 o'clock at night. And so this is another option. We do a diabetes on demand 3 days a week. There were no one coming yesterday. I think she saw if 9 people in from noon to 5, right? So it's coming around so that you could get in there. They could at least order a PFT. Like, I know Mankind will ship you a PFT to your house for free. You don't even have to go in to do it, right? So I'll get you one of those. But even if you have the results, you got to have someone prescribe the drug, right? So I think that's a big part of it too, is you need both sides, but we're all struggling with that follow-up. I mean, my next follow-up is December, and I'm an NP, and I haven't even put in some of my vacation. It's terrible, and it's not. We don't see it getting better anytime soon. So Afrezza is now 6 and up. So what does that tell me as a clinician? It talks about the safety, right? I don't see peds, but there are a lot of people who are like, ooh, but the lungs, ooh, but the lungs. I think now Afrezza's been out long enough that I think people are now much more comfortable. And when you get FDA approval in pediatrics or in pregnancy, it's a big deal, and it tells us that even the FDA thinks this is safe enough to use in children. And you're right, Sarah. A lot of people, I mean, I have it. I have it as you have glucagon as a rescue for lows. Everyone should get Afrezza no matter what as a rescue for highs. I have it in my bag. I mean, do I use it every day? No, absolutely not. But it should be part of our toolkit for everyone. So I think that we'll start seeing more of it because of that, because I think clinicians will feel better. The things about peds, and I don't know how many peds are on here, but the thing about peds that we have to think about though is school lunch. So I couldn't give this and have the child like stroll down the hallway and visit the art room, and get distracted. If they're going to use a Frezza before lunch, they're going to need to do it right before lunch, right? Like as they're walking into the cafeteria kind of thing. So there might be okay, maybe they get an injection at school just for safety if they don't have someone there that could give it at the time of needing it, right? So there will be some tweaks around it, but I'm a huge fan, and I think that more people should have access to because it works right away, you guys. It's in your system, and I mean, it's like I've seen a blood sugar. Not that I ever have highs, right? Because I'm, of course, perfect of 300, 350. And all of a sudden you're like, okay, here I go. And it comes down so quickly as opposed to that 4 and 5 hour waiting, angry bolusing, stacking craziness that you do, that we do when we have when we have pump issues, right? So I'm excited about that. Does anyone have any other comments about Afrezza? Nope. Okay. So,
Mr. Johnson has
oh,
a
Scott.
question over there.
Uh-oh.
Scott.
Sorry, Scott.
Just a quick comment that, and I shared in the chat, but I recently tried it and it's it's really cool. It's a cool tool to have in the mix.
It is, isn't it? Right. Like you might not use it all the time. You guys, I take a little bit of insulin, but the idea, because the lowest dose is 4 units, but it absorbs as two. So it's not the same as, it's just a little bit different, right? But I will tell you that um, this is a really incredible extra tool to put in your tool bag. I mean, and we do use it for people who don't want to use a pump too. We use it for people who want a basal bolus only. So on MDI. So I'm pretty excited about it. Yeah. Brenda?
Yeah, I just want to say I find it so easy to use. I use it for rapidly digesting high carb foods. Times when I want to be quote unquote normal on vacation and have that sugary cocktail, there goes my Afrezza because it's
Yep.
just 2 units. I can use
Yep.
2 units for a lot of things, correction multiple times, or it's just a specialty tool for specialty situations, but also especially for stubborn highs. And I use it over the top of my AID. I was previously on Control IQ, absolutely no issues, no lows because the AID is preventing the lows when you're doing Afrezza, the same as it is when you're getting the rapid insulin through the infusion. So I just love it as an adjunct tool.
Awesome. And I will tell you that they are working on a 2 unit, which will um the 2 unit will absorb as 1 unit. They are working on that. So because we've all said, come on, get us another, right? Okay, real quick, we're gonna keep going. Sorry. Um high dose semaglutide, right, for obesity, but so many of us are using GLP-1s now for people with type 1, right? They're not FDA approved. I cannot wait for FDA approval. If I can reduce your risk of heart attack and stroke, that's my job. And Viral Shaw at ACE this year put up a slide that said the ADA guidelines now say in 2026 that you can have a dual diagnosis. You can have type 1 diabetes, be antibody positive, and have type 2 tendencies, right? So that's insulin resistance, excess weight, those kinds of things, right? So I feel completely fine with using dual diagnoses because Viral Shaw told me I should, right? But truthfully, people do much better. And there was some data on use of GLP-1s and type 1s. Insulin goes down, insulin usage goes down. Actually, interestingly, because we've always backed the basal down a little bit, depending on the A1C, and depending on the AID, if you're using AID with it. But it really is mealtime insulin that you are using much less of. Like two-thirds of the reduction, if not three-quarters, is actually mealtime insulin. It's not the basal. We tend to back things down. Some people are like these super responders to GLP-1s or GLP GIP. And so we just want to be overly cautious and then we slowly increase the insulin if needed at the time. So that was pretty interesting. So a handful of others real quick. I'm going to do this in a 3 minutes. Continuous ketone monitoring. There was so much talk on continuous ketone monitoring because Abbott's continuous ketone monitor did get FDA approval outside the US. It's coming sometime this year to inside the US. It will be paired with the continuous glucose sensor. In the beginning, it will not read to a pump. So what all of us go is, oh my gosh, if you start to get DKA and blah, 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 it's not going to happen right away, right? But there was some education around what does small ketones really mean, right? I don't eat breakfast one day and I'm late with patients and my lunch is and I'm angry by 1 o'clock. I'm not very pleasant, but I might even be having a little bit of ketosis, but if I eat, I'll be fine. So how do we define those numbers and what we're going to do about them was still a big talk at ADA this year. Omnipod 5 with a new target of 100 and improved, enhanced, they called it. Diana Isaacs and I have a podcast and we interviewed Trang Lai, their chief medical officer, and she called it the enhanced AID. It stops kicking you out of auto mode now. So that's over. It will alarm and say, hey, you've been high for a while, but it won't kick someone out, which is huge. So a new target of 100. And in that target, the studies that they did showed no increased risk of hypoglycemia. They also talked about the fact that only about 35% of people have a target of 110 now, which is just a tragedy to me. I know kids sometimes will set higher. I know older patients who are frail are set higher, but the majority of people who have diabetes, who you expect to live more than 15 years from now, should be on the lowest setting that they can tolerate. I know there's fear of hypoglycemia. I know all those things, you guys. I'm a clinician that practices every day. We got to get these numbers down because we see the difference even with A1Cs of 7.5. Some people develop complications, don't they? And so because I can't tell which ones are going to get them and which ones aren't going to get complications, we have to be aggressive as we can. So there is a new target of 100 in enhanced AID, which means they're not kicking you out. And Omnipod 6 is coming in 2027. And they did announce that they're doing completely for type 2, no touch AID. So people won't have to bolus at all. Okay, Tandem I already did. The Minimed company showed their new pump at ADA, which is interesting, but their algorithm in the new pump isn't changing. We love their algorithm. We weren't always happy with their CGM, but now they have two CGMs that we can offer. The Instinct, which is the Libre 3 Plus, rebranded. It's truly the same sensor, rebranded for Minimed and made for their pump specifically. And then their Simplera. So the Instinct is a 15-day, Simplera is a week. So they had their new pump and it was a pretty big splash. It's there are countries in the world because remember ADA is international. There's about, were there 12 or 14,000 people that came this year. And so it's much bigger than ADCES if you're an ADCES person, right? And a lot of those other outside US countries, they only have mini-med. So it was it was very popular. And then iLet, finally, I'll close with iLet. So the iLet insulin pump, you set a weight and that's it. And you set more than the target, usual target, more higher than usual, less than usual. You set a regular, you tell the pump when you eat, this is a usual meal, this is more usual than less usual. That's it. Those are the only settings for this pump. They actually presented every single patient data that they have. And they're an interesting group, right? No other pump company has ever presented all their data. No other pump company has ever said they do studies and they say, well, we looked at people whose A1Cs were this and we pulled out this. And Stephen Russell, their chief medical officer, is like, why can't we just show everything? Why can't we show that sometimes, like, we do the best we can and this pump does what it does? You can see on their data that we put someone on it with an A1C of 14 and it came down to 8. Well, guess what, you guys? We won there, right? It's not at 6.5, but boy, did we win. This person, their outcomes are changing as we speak, right? So they did a really nice job. And I think all of us, when we go to design studies or think about the studies that you're doing in your own practices, should think about that. Like, open your doors and let people see what's really there. We all have people that struggle. We all have people that don't show for their appointments. We all have all of that. But, I thought it was very impressive that they just said, here's everything we have, right? And just open their doors like we're not afraid. So that was a really, really interesting take on how to do things different, I think. So with that, I wish we had more time because I have other things, but this is like ADA is so big, you guys. And if you're coming to ADCS, come find us. I'm sorry Diana couldn't make it today. She is in like central time zone, but thought she was in, I don't know. I don't know the whole story. It's like she wears two watches. When you meet her, if you haven't met her in person, she wears two watches, one for her step count and one for her time. I don't know. I love her to death, but like, so she called me in a panic this morning and here we are. So, I apologize for my partner in crime not being there, but we did do a couple of ADA interviews on our podcast as well.
Well, thank you so much, Natalie, and our appreciation to Diana for attempting that as well. But thank you for going through that. These takeaways have been incredibly helpful. I feel like we need more of these little clinical, pearls as we go along. I think it's really helpful for us to all to talk about. But I really appreciate everyone's time. I know we are over time here, so thank you all for staying on. It really means a lot to all be in this space and learn together. And Sarah, through our updates in the chat here, Sarah, is there anything else that you need to wrap up with, or Julie?
No, I think the last thing I'll say is like look out for that advocacy webinar coming on 6/23. We talked about that a little bit at the beginning of the call, how we can all, advocate for change more. I'm actually really excited to be going to Hill Day with Deepak next week with Len, our CEO. We're learning how to be better advocates and take what we're hearing from all of you onto bigger stages and to bigger audiences too. So really excited about that. And we'll bring back learnings from that as well to you at the next meeting. So thank you all. Check out the webinars, the events, the podcast episodes. There may even be one with Natalie and Diana on the pipeline to further this conversation because I think we could have 8 sessions on this. So stay tuned, stay up to date, and thank you guys for being here.
Bye, everyone. Thank you.